Welcome to the seminar. Today we have speaker Alexandre, who's a PhD student here. So please welcome.
Thank you. So thank you everyone for coming today. So my research, as most of you already know, is about assessing the use of computer simulation that use virtual patients to teach medical trainees. So I'll be talking a bit about that today. So what's my research about? So the overall objective of my research is the production of a set of virtual reality training tools for different medical trainees. The main idea is to have virtual characters as patients that would allow some real-time interaction and communication, and as well have some kind of immersion component in there. Then the second objective is with those students to actually test those virtual reality artifacts as part of their curriculum and see if it can actually affect their learning, if it can actually help them to learn their skill sets. So my research is based on two case studies. Case study one takes place at the University of Canterbury. I'm actually doing some work with the communication disorder department with the audiologists over there, with the students. And the second case study is a collaboration with Christchurch Hospital and the nurses at CPIT. So that's more targeted towards doctors and trainee nurses. So a bit of terminology first, just to see what you're talking about. So what are simulations? To put it in short, simulations are working model of reality. I'm not going to enter into the deep details, but let's say that for the sake of what I'm talking about, we got two main delivery types for simulation. Role-play simulation, using people that actually practice together following scenarios, and computer-supported simulations. Then all those simulations can either be mediated by tutors or facilitators, basically help the users and try to challenge them and get some direct feedback to them during role-play simulations, or they can be autonomous as well. So basically, you have your system, you train by yourself, and then you'll get some feedback later on from a teacher or something like this. So simulations are used everywhere. On the top left, you can see some ladies who are practicing their business skills for some new kind of venture. And you can also see they got a teacher next to them, which acts as a facilitator and also gives them feedback directly. On the bottom right corner, you got simulations that's supposed to teach how to operate trains. So that's autonomous. You can just sit there in front of your computer and practice your skills and see what the whole thing is about. And then we got two examples of simulation using mannequins. On the top right, it's military paramedics who are training revival skills on a mannequin. That one is autonomous. And the one on the bottom left, which is basically what happens at CPIT for the nurses and doctors, we got in the back two intern trainees who are training with a mannequin. And you can see that the view is from the room of the technicians, who basically operates the mannequin, change all the vital signs that refer to that patient. And so basically, there's two ways of using mannequins here that you can see. One could be autonomous. You basically program the whole thing first to react according to a specific scenario. Or you can have someone in real time that operates it. So what are the advantages of using simulation? Well, first thing is to train for low-frequency events. In the medical case, it would be like training for some really rare pathologies. But we could also have like simulation to train for like mass panic incidents or things like that. Second advantage is actually the repeatability. Once you went through a scenario, you can reflect about it and then choose to repeat it. See if other actions actually lead to a different path and a different outcome. Try to figure out why you didn't get the best outcome in the first place, the first time you tried it. That's one of the advantages. The next advantage is it's a safe environment. You're not going to cause or receive any harm in one way or another. So that actually gives liberty to the user to train their skills and get some experience before facing the real world and its challenges. At the same time, it also does raise the students' confidence and the user's confidence. Finally, the last advantage is control or standardization. Basically, if a course coordinator or a doctor sets a simulation, once the simulation is set, all the students or all the users are going to receive the same thing, which is going to be exactly what the course coordinator wanted. Looking at it that way, all the students will have the same training and or the same assessment. That's what we talk about when we say standardization. Then looking at the term virtual patients. Well, initially, virtual patients, like early 90s, that referred to cases that were made of videos, paper representing results of patients, some other media, and you just have a bunch of all that collected together. You would give that to your trainee nurses or your interns, and that would be called a virtual patient. 10 years later, early 2000, the virtual patients have a proper embodiment in computer simulations. So we end up having like virtual characters that play the role of patient, and that's what I'm interested in. Computer simulations that use virtual patient have been deemed a valid alternative to actors. It's referred to as SP, that stands for simulated patient as well. That's basically actors who play the role of patients in role-play situations. And so yeah, virtual patients have been deemed a valid alternative to those actors in different fields, ranging from like basic clinical history taking for abdominal pain, cancer awareness, heaps of different things. So here we got a few examples. On the top left, we got a simulation where a nurse is practicing talking and giving information to a doctor while doing surgery. On the top right, we got a scenario that is about hallucination and schizophrenia, as you can read on it. On the bottom left, I'm not sure if you can see it properly, but we got a user that interacts with a patient directly using speech recognition. It's a patient that came to a clinic complaining about some abdominal pain. Then another huge user of virtual patients and virtual characters in simulation are the military. Here you see a picture from a scenario that's meant to assess military coming back from the war to see if they suffer from post-traumatic stress disorder. So basically you talk with the guys and see if you can get any clue that something's off with them. And then you got something similar on the civilian side with a virtual character representing a woman who suffered from assault. Anyway, once again, the advantages of virtual patients. Well, it does simulate patient-trainee real-time exchanges. It's more realistic than those former paper-based or other media-based cases. You get some immediate feedback because you can talk with the virtual character and he answers directly. Once again, we got that control or standardization. So basically, once a scenario is made, you can give it to a whole range of users or students. They will all get the same thing, same training or same assessment. Depends basically what you use it for. And it's repeatable as well. So today, I'm mainly going to talk to you about my case study 1, which is a work I've been doing with trainee audiologists at the Communication Disorder Department here at UC. So it's basically focusing on a few studies we did last year. So first of all, why are we working with them? Well, to start with, trainee audiologists in New Zealand have a very limited access to practical training. The way it works out is that right now in most universities here, in Queensland or in Auckland, they actually have like 1 day a week where they have a placement in clinic and a chance to see real patients. But within that time, they actually have a more limited chance to actually get some hands-on training. What would happen is that 1 day a week, the students would go to a clinic, see real patients. So it's basically 6 hours. But out of those 6 hours, most of the time, we'll just end up watching a proper clinician doing all the work. You'll hardly ever get a chance to do any actual work. Consequently, because there's so little opportunities to allow for the practical training that's necessary for those doctors, we have a very limited recruitment in that university course across all the universities in New Zealand. So in terms, it's actually going to cause a shortage of experts in the profession as well. Okay, so what did we do? We made something that's called the clinical audiology simulator. Here you can see it went through a very iterative process. And that's basically on the left what I started with and what it looks like today. So initially, we borrowed an interaction platform from our colleague of the University of Florida, of the Virtual Experiences Research Group, that allowed some basic interaction with virtual characters. From then on, we started building some features that would allow to train the different procedures necessary for audiology students to train their skills. And then we did implement better graphics. And basically, right now, we end up with a simulation platform, 25 current patient, complete cases that the students can practice with. So what's the procedure about? What would a student do in reality? So it's mainly 4 steps after you select which client you want to see. First one is called a clinical history taking, which is basically a preliminary interview that you do with the guy to see, well, why he came here and try to get some clue on what his problems may be. Then you got a procedure that's called otoscopy, which is basically a really fancy word to say you're going to look at the patient's ears. Then we got pure tone audiometry, which is about determining hearing thresholds for the patient's ears. I'll get into the details shortly. And then from all the preliminary information, you will have to come up with a diagnosis, and you will get some feedback on that. So first thing first, clinical history taking. So it would look a bit like that. You'd be sitting in front of your computer, type questions to your patient, and he would answer back with basically, so why did you come to the clinic today? And with that, by repeating that process of asking questions, you will basically get all the necessary first impression and first informations before carrying on and knowing, well, what exams to do to the patient. So how does that work really? We're using Visual Studio to implement the simulation. And within Visual Studio, that's basically audiology app, audiology library, and the embedded RAN wrapper, we are displaying a window, that Augur window, which is the main rendering engine. So all the graphics side, the 3D models, that's handled by Augur. So what happens, basically, when you type a question or ask something to the patient, it's going to send a message to a speech server, which is something different we got on the side. In that speech server, you got basically a script with all the questions that you can ask the patient, all the possible answers. So what it's going to do is it's going to cut your question in specific keywords, go through a list of triggers, and if it recognizes those keywords in the question you asked, it's basically going to fire the appropriate response. Then send a message to Augur through that library called RANcore, which is then going to do all the lip synchronization and start the animations on the patient. So then you'll be repeating that process of asking questions to the patient to get basically all the information necessary to complete that form they got in clinic. So it's basically, why did the patient come here? Some subjective answers of which ear is better, when did your problem start, have you got any family history, what kind of situation affects you the most, etc. Do you have some balance problems? All the necessary information that could give clue about some specific problems straight away, within 10 or 15 minutes. Then you would usually follow up with that otoscopy procedure, which is basically looking inside the patient's ear. So those are basically just pictures of eardrum we collected on real patients in the audiology clinic, on campus, and in the clinics in the vicinity of Christchurch. So there can be different problems. There could be some wax occlusion, some bleeding, inflammation. And that would give us more information on the specific case. Then, yeah?
The otoscopy image kind of captured picture from a real person? Or is
all the picture, all the data, all the collection of pictures we have for the different pathologies were taken on real clients, real patients, in the clinic that's either here on campus or in the other clinics in Christchurch.
So those pictures are from real
real persons, yeah. Then we have a procedure that's called pure tone audiometry, as I mentioned earlier. So basically, you use what's called in clinic an audiometer to present different types of sound to the patient's ear, to basically determine the minimum level to which is going to answer. And we do that across a range of frequencies, ranging from 250 Hz to 8 kHz. So basically, the main thing is that minimum level for which the patient can hear the sound. And then there's some deeper procedure, but I'm not going to enter into the data because it can get really complicated. But basically, as I said, minimum levels. Then from all that, you can come up with a diagnosis. So you can select different pathologies in a list. And a patient can basically have up to 4 different pathologies, depending, because one ear can have 2 different pathologies. Then you can just add a comment on why you made the decision for the different pathologies and on your diagnostic, and then submit your results. Once you submit your results, you'll be presented with the answers to the case, basically. Okay, you messed up here, you did right there. And from then onwards, you can choose. If you want to understand, or if you, oh yeah, okay, that's why I made the mistake, you can choose to repeat the same case and try something out to see, okay, that's why it actually didn't work out the first time I did it. Or you can just use change case and load a new patient, try something else. So what we did, we basically did 2 studies. One focusing on pure tone and masking procedure, which we just talked about, and the other one focusing on the clinical history and the interview part. So why did we do that as 2 studies? It's basically that as part of the course the students are following, the necessary knowledge to operate and to conduct those procedures is spread across the year. First part of the year, they're looking at pure tone and masking. Second part of the year, they're looking at clinical history taking. So we split it that way. So the first study about pure tone and masking audiometry. Participants, first year Master of Audiology students. So as I mentioned earlier, really small classes, only 12 students, so 12 subjects. Why did we choose them? Well, they are first years. They basically have no previous knowledge, no previous practical knowledge of the field, and they would be the ones who would benefit the most of it. Even more, considering that one critique that's been coming more and more is that those students, at the end of the year, they have a placement of 3 months to punctuate the end of the first year. And let's say that the people employing them were not always too happy with their level of skills. So the study design of the first study, we split those 12 students into 2 groups according to their GPAs. So just kind of made it even. And then we had a training period of 2 weeks where one group was training using the computer simulation on top of the traditional teaching, which would be classes plus the day a week of in the clinic. And the second group was just doing the traditional teaching. After that, we would have 1 week of common training on the computers, and then we would have a test. The test would actually fit in the course as a midterm, and on top of that, we added a role-play assessment as well to collect another set of data. And then we would reverse the situation. The group that had the simulation before will now only have the traditional teachings for 2 weeks. Then we would have another week of where both groups would have the simulator, and then a second test, which is basically the end of term assessment. So that's usually, that's kind of a atypical ABBA design. But as part of our collaboration with the course coordinator, we had to have those extra weeks of common training before the assessment to make it fair on the students, because those assessments were actually part of their course. So what were we looking at? Mid-term and end-of-term assessments. So those were assessments using the simulator. The students basically had to complete 3 cases, and we did an average of all that. And then we did a role-play assessment. So we would basically have someone playing the patient, as you can see here, have a student who's operating the audiometer in clinic, and have someone marking the student on the background. The third measure, is the student's perceived level of learning, which was a mean of a 5-point Likert scale. Then we got our second study. Same participants, just in the next term. That time we're focusing on the interview or the clinical history taking. So why did you split it? As I mentioned earlier, it's later in the year, and we also had the chance to test the settings first. This time, thanks to basically our first study, where we were a bit more lenient concerning the design with the course coordinator, we were more able to do what we wanted. We got rid of that 1 week of common training, and we basically had a baseline, 1 group training with a simulator on top of traditional training, 1 group just doing the traditional training, and then another assessment. This time around, we didn't take GPAs to split groups. We thought a baseline was necessary because for interview or clinical history skills, well, GPAs was not considered really relevant to the ability of students to deal with people directly. It's not a paper test, it's a bit different. And the only assessment this time was done in role play. So what were the measures? First measure, it's a subjective measure of students' confidence. So it's part of a questionnaire that was handed to them before the role play assessment and after the role play assessment. The next 2 measures are verbal and written accuracy. Verbal accuracy is what we call, basically represents the amount of information you could get out of the actor that plays the patient. So basically, by talking with him, out of all the information you could get, how many you get out of him? And the written accuracy represents basically what's the percentage of those information you collected from the patient you were able to report correctly on the sheet I showed you earlier. We also looked at the number of questions asked, and we had a measure of efficiency, which is basically number of questions asked on amount of information you retrieve for the patient, which is basically if you could get more information from the guy with asking me, while asking him less question, it's considered better. So overall for that, unfortunately, no significant differences on the measure tested between the 2 groups. So we got a few leads of why it came out that way. Maybe too low statistical powers. Well, 12 students is not a lot to work with. But once again, there's not much we can do about that. System to improve? Maybe. We're doing that either way. So consequently, we need a few follow-up studies for that. Anyway, what we do know, however, is that using that simulation did not impact negatively on the students. It did not deteriorate their training. And what we did actually do, on an average of 5 hours of training for those students across the 2 studies, we actually allowed them to access way more patients, way more different cases, like patients suffering of different pathologies, than they would actually do on their placement in clinics. So basically, in the equivalent of what they would be doing one day in clinic, they had the chance to see what they would do in weeks in traditional teachings. And we also allowed users to practice at their own pace and within their own free time. Because basically what we did was install the software in one of the tutorial rooms, and we just let the students access it, and it was open 24/7. So a few follow-up studies. The first one would be a similar study with a control design like the one of study 2 I just showed you, with the new first-year students from this year. So that's actually starting in 10 days. So as I mentioned, more control design. Now the course coordinator is a bit more lenient with the stuff we want to do, so that's working well. And we did improve a few features. So I did some work on the scripting of the interviews to make the patient more responsive, to make sure the students will not get frustrated. We improved the graphics and also the ergonomy, usability of the interface. I also got a few new focuses. I would like to try and assess effort on the student side. And I also would like this time to collect concrete data on what those students are doing in clinic during their placement, to then have some proper data to compare to their training using the virtual patients, quantity-wise. Some other follow-up studies using the same system. I got a feedback study that's using that simulator as well. So basically, we are going to compare different forms of feedback between like formative and summative feedback during the training on the simulator. So it's basically giving advices and to the student while he's doing it or at the end, which one helps him more if we want to learn the concepts. And this time we got actually a different target audience because we felt like we would need bigger numbers to be sure of the results. So we're going to work with speech and language therapy students. So basically, we'll make them a class first to have the basic concepts, then test them. And we got another study that's basically focusing on a speech audiometry procedure. So that's basically another test that's part of a battery of tests that those guys have. And that's what Jacob's working on. Similar setup, but different tests, yes. So in conclusions, computer simulation making use of VP can be used to allow audiology training to expand more patients. And computer simulations and VP offer a wide range of practical advantage, which is actually really neat. Because still, while we didn't have any significant difference on the results, we can see that this simulation did help the students so far. And it needs to be looked in, well, deeper. It did allow them to get their training during their own free time, reflect by themselves. And as I mentioned earlier, we allowed them to practice on just so much more patient than they would do in clinic usually. So that's pretty much it. So our collaborators, University of Florida, CPIT, and University of Canterbury's Communication Disorder Department. Thank you. So if you got questions, please go ahead.
Have you looked at the cost perspective of using comparing the cost of traditional training and training using the virtual patient? So since you've mentioned there was no difference between their learning, maybe better to say.
But that's something we talked about with Christoph actually, looking at cost. But we decided to end up looking more on the effort side of things, because, well, basically the project started really slowly because collaborators were not that interested in the project, so cost would not be that relevant, because, yeah, that's pretty much it.
Yeah, but in my view, using virtual training systems also.
It does incur a cost that can actually be pretty important from what I read as well. And that's actually a project that had massive fundings to start with. It's just that looking at the details of the project and looking into the financial might be a bit complicated at this stage. But what we can look at, however, is the cost in terms of people necessary to run role-play simulation compared to having just a simulator installed in a computer room, having someone that can access it whenever we want. And, well, basically, as in cost, the time it takes.
It's a sort of very multifaceted, I guess, because in the end, you can then argue, okay, well, if you have a computer somewhere, we have continuous support and continuous further development as well. So I think you probably need some business people to really make some of those calculations. Otherwise, it's sort of a really. I think this issue comes up with a lot of different projects. Arguing, well, is it any more cost effective or not with those new systems? I'm actually. It seems a lot more straightforward and easy to answer questions than it probably really is in fact. Because which factors do you take into this equation?
Yeah, I was just mentioning because, like other simulators, like replaces spending consuming materials, like for instance, if it's a paint spring training simulator, then you don't use the paint, so you can calm down.
Okay. You have lesser costs, yeah.
Cost of the materials, but since it's a kind of
well, that's another thing. When you look at the cost of simulated patients, of those actors, the professional ones you should use in role play, they're actually pretty expensive as well.
So,
yeah, and that's why basically what most of the people end up doing is like they don't have any professional to do it. They have someone within the department who like, okay, I'm going to play the patient, but then is it realistic enough? Is it controlled, standardized across all the different students? Are they not going to be biased towards some students they consider better, they want to give better marks? We have all those problems as well we don't have with the simulator, for instance.
Yeah, anyway, I think it's worth if you could come up with some kind of course that is
okay.
for a traditional method, then even if you don't compare it exactly or directly, then you can just mention traditionally it costs this kind of.
Yeah, well, what I was interested in doing, like in that follow-up study, was looking at cost in terms of people and time, mostly. Money is a bit, well, as Andreas suggested, I don't really have a business background. It might get tricky, but it might be worth actually taking a shot at it.
I think it's probably even more interesting for the medical part than for the audiology, because it's probably a lot more obvious that it's really expensive to run those.
Yeah, true.
Especially for the medical part of the project. See those mannequins, when they run those mannequins, they have several medical staff.
Yeah, basically you need an extra 3 staff to run a simulation using mannequin.
And especially for doctors, you know what they charge anyway for their hours. So it's probably quite obvious that just costs a whole lot of money. Because they need someone to observe the whole thing, they need somebody to play the mannequin, to give all the answers, and another person, sort of a nursing staff as well. So it's, at least 3 people, professionals that have to be on call, that you take away from other patients to run those simulations. That's probably a lot more obvious in the medical.
Yes, it is. It's actually something to look at, yes.
When you've done the study and you've what was their response to using virtual patients? Did they enjoy actually the experience? Does that have a huge impact on how effectively you learn?
Yeah, well, it's a similar effect you can see in a lot of paper, because it's a new mode of training for them. They would like show some sort of enjoyment. Then usability-wise, because of the field, there are not people who are all really computer literate, let's put it that way. So on the usability side of point, we're a bit like across the board.
So did anyone say they kind of really enjoyed that experience over
Most of them actually did, yes.
compared to what we've had before?
Yeah, I know. They really actually enjoyed doing that, and I'm actually still in touch with all those participants who actually helped me do further work on the simulator afterwards. They're all pretty keen to help me out to still give me advices of some new features or help me with some scripting. And now it's actually been a blast working with them, and I know I'm still in touch with them, and yeah, that's good. Thank you.
Said earlier that they validated the equivalency between virtual patients and simulated patients. I was wondering whether that means to replace it entirely, or there's validation enough so they can do a certain amount of tests, but in the end, presumably you still want some interaction with real people so that you can actually know how to deal with real people who respond to things like lighting or whatever, just like facial features.
At the end of the day, as it's the case with most virtual patients, it's not meant to replace traditional things like basic experience with real patients or with actors. It's more meant as a supplementary tool.
Right. So my question really actually is, how much of that real simulated patient can you take out percentage-wise numerically, and how much you have to retain, and do the tests actually evolve and change so that you end up taking a lot of things you used to do with simulated patients, now you can do entirely virtual patients, but there are things that you can't do with virtual patients.
I actually haven't been looking at how much of the real stuff you can remove thanks to that. It's more like to see how adding that could contribute for more or help them out. I'm not touching at the traditional training. That's not something you could actually do in educational settings like, hey, so I'm going to use half your students and just ask them, well, not to train as much, because I want to try that new things,
Well, no, but presumably this is going towards a direction where somewhere down the line, when a new place opens up, they look at the kind of tests they want to do. They say, well, now we need, instead of N number of simulated patients, have M number of N less than N, because now we have some virtual patients.
Sure.
And
Well,
that's the result, right?
that would actually be, I see your point, but that would be very specific first to the field it's used in, and then to the quality of the simulator and the quality of the students as well. But once again, I haven't been focusing on that in my studies. But yeah, it makes sense that it would vary from one place to another, the needs for both simulated, quantity varies, for both simulated patients and virtual patients or simulators. Yep.
Yeah, I had a question. What sort of natural language processing are you using to interpret the user's questions?
Well, everything's script-based, so I basically got a huge file of the background. And, well, I got a dictionary that's used when I use speech recognition, which I didn't in those experiments. But basically, building a script is an iterative process. You start very small. What you'll do, you'll have your typical answer for one case, then run that through a few students. The virtual patient is not going to reply at all. And then we're going to add those sentences as part of triggers of the question you can ask, and basically do the cut on keywords. We got an algorithm that does that basically looks into sentences and sticks out what it thinks is specific keywords in that. That was something that was part of the initial system. However, I chose not to use it anymore in that particular case. Well, mainly because the difference with what the guys in Florida do compared to me is that they do some more generalized assessment. It's basically about getting information of the patient, not about interpreting them afterwards. In my case, I may have questions that look a bit like each other. And I want to make sure that when you ask something, you'll get something that's really adequate, not have a different answer. I'm not sure you're really following me with that, but I did end up doing most of like splitting phrases into key phrases and making sure the triggers were right. I did do that manually, because that's basically the only way to make sure it's accurate. And at the end of the day, I would rather have my virtual character be like, once in a while, okay, I did not understand that, can you rephrase, than having him answer back with something that's wrong, and that could lead to a wrong diagnosis.
So the way you did it, where the people who used it, were they sort of satisfied with it? Did they feel like they were actually interacting with the person?
Well, some actually, even more at the very start of the study, a few of them were really frustrated because it would work fine for a few users, and then you would have the odd student who actually asked completely different questions that nobody else, when you recorded all the triggers, did, and like, So then that's another reason we had to do some extra work on the scripting, and that's why I've been seeing all those students to do more of that over the past month or two. Basically what I did is that I had 2 students coming once a week. We did some work, okay, try to break it down, try to make him not answer. The more you do, the better. And then I added all those into there. And then the week later, more students, and so on and so on. And now we're ready to start the new study.
Let's give thanks to the speakers as well.
Thank you.